I'll just carry on like admitting people in.
Okay, so so this is all really new to me. So really it might be a bit clunky, and hopefully as the months go by, you will notice us getting better at it. Hopefully, but really, please write questions. Wanted to try and be as interactive as possible. That's why we sort of Sarah and Rachel come in as well to try and have just discussions, so you can really get a feel for what it's like and some of the issues coming up when you're at assistant psych level, and then please ask me any questions as well. That's not a problem.
I guess what we want to sort of start off with saying is like what today's topic is about. So it'll be about the psychology assessment process. I know for me, when I first started as an assistant psychologist, it was just like, oh my gosh, there must be like a crazy, like super crazy process to it. But as I started working with you, it's much more simple than I thought. So I guess like one of my questions would be, if you could explain a psychology assessment, how would you start it? Like what comes to mind when you think of an assessment?
Yeah, you're absolutely right there as well, because if you don't know what it is, your mind sort of jumps to it being this some sort of really difficult process, and a process that like, well, I just never learn how to do. You know, you get really so you start putting yourself down or just making it harder than it is. Essentially, a psychological assessment, as a psychologist or the psychology members of staff working in a team, don't forget, if you're on the last webinar, we talked about the MDT, the Multi-disciplinary Team. So you will be working, if you're working as a psychologist in the NHS, you'll be working as part of an MDT. So other professionals, nurses, doctors, social workers, occupational therapists. So as the psychology team, we will not be the first point of contact. Other members of the team will have seen the patient first and gathered some information, and then we're sort of a secondary service within the team. So there will be some information previously gathered on the individual. So that's to bear in mind as well, to think about how many times a patient may have been asked questions about their life events or life history. But generally speaking, as a psychologist, we have a lot more time to really try to understand what's going on for a patient. And try to ask maybe different questions or ask more questions to really start to understand the context about things, and try to really understand the person as an individual rather than symptoms. You know, and nurses, care coordinators really don't have that luxury. Really, there's a lot of time pressure in the NHS. We're just having a conversation about this just before. Really, they have high caseloads and really have to get their sort of the first assessment, the sort of risk assessment, sort of done really quickly. There's lots of sort of, it has to be done within a certain amount of time, usually 48 hours, or there's a turnaround to see the patient. So there's a lot of pressure on nurses to get the information, so it can feel for the patient, I imagine, really just like they're a tick box sometimes, you know, or they're just like, people are just gathering information without really thinking about like what this individual needs or what this individual is trying to tell them, you know, and that can feel, I imagine, not a very pleasant process. So we have quite a luxury as a psychologist, really, because we are expected really to take a bit more time to really sort of try to understand. You know, and so think of the psychological assessment not as like an assessment as in I'm going to go and fill in a sheet and then it's done. Think of it more like as a phase, an assessment phase, you know, and give yourself, and your psychologist will give yourself enough time. You know, that assessment phase can be as long as it needs to. Do you know, before you've gathered enough information to reach some sort of hypothesis about what's going on for this person or what you need to focus on. So your assessment phase is really where you're gathering information to then sort of formulate then you put the information together to form a treatment plan or care plan and interventions. I'll come on to that next one. So what really is the psychological assessment? I mean, a good psychological assessment as a start really is to gather, it's helpful to gather information, so a history on the individual. Now, you might not have a lot of information on the particular patient, or that we might have a lot of information already, but you're still going through the process of gathering information about events that they've gone through. So as a start, you'd be gathering sort of a picture. You'd be a picture of the events they've gone through, just like something that might help. So I don't know if I got you guys to do this. So you'd be gathering like a timeline of events, and don't feel. I remember feeling quite awkward asking patients about their past if they didn't bring it up, and feeling like it was something I was trying to get them to do for my gains, you know. But actually, the mind really likes telling stories, and your patients will really like to tell their story if they feel they're being heard. If they feel, did you want to say?
I was just thinking, like that. You saying that brings a question to mind. That, like, say sometimes you do have some clients that are very like protective of what they've been through, and they don't want to talk about it. How do you still like get that information without sounding like rude or too invasive? Yeah. How do you do that?
Well, everything that the patient is presenting is helpful. It tells you something about them. So if they're telling you, or if they're saying they don't feel ready or want to talk about that, then that is helpful information. You don't have to feel. I think I remember feeling a real pressure as an assistant psych, a pressure that I admittedly sort of put on myself because I didn't know what to expect. Someone else needs to get in. But a real pressure to gather information, as much information, almost like the more information I gathered, to show my supervisor, look how good I am at collecting information and history on this person, you know, as if that sort of meant something. And yes, history is helpful, but actually, you know, what the patient tells you or what they can or cannot disclose is helpful to pay attention and to tune into as well. And a psychologist would be looking to do that in our assessments, you know. So I've sat in some of we sat in some psychiatrist assessments or some, and they will just ask, you know, very bluntly everything and really push and push. And that's a different sort of training. So as a psychologist, if you'd be intently listening to what the patient feels able to disclose right now, and that is helpful in itself. So as a psychologist, you're holding all these things in mind. Okay, so when you're talking about psychological thinking or psychological assessment, it's paying attention to different things without making judgments or decisive or assumptions or decisions. You're just noticing loads of different things and holding that all quite loosely in your mind, and that sort of all comes together as a formulation in a later stage. But you're still in the assessment phase, so you just note that in your head. You don't particularly do anything, because the most important bit at the start is developing a therapeutic relationship. Everything we know from research, you can use any type of tests or whatever, but if the patient doesn't feel trust or feel like you want to hear their story, you just put yourself in the patient's shoes. If you're not getting sort of a vibe or an instinct from this person that they care or they want to hear, then you're really not going to open up. So just be listening and just be focusing on trying to develop that sort of therapeutic relationship.
Like in the prisoners, that I found that people view you differently from officers, so they are actually more likely to tell you because they see you there as to help them. So I've had someone who I've met the first time and has worked with others in the team and then started telling me things straight away, and they were like, why would they tell you that? And it actually turned out to be true. And I had to raise concerns about it. He'd never met me before because he saw me as someone who was here to help rather than just a tick box, or just like, I'm obligated to see you once a month.
That's a really good point. And you would say 9 times out of 10 people, like when they're sat in front of you, they want to tell you a story, so you just go at their pace and listen to your instincts. But you will be thinking as part of the assessment, if you want as part of think of a process that you're going to go through, you do want to gather some sort of timeline of events, because it helps us to build up a picture of what the person's gone through, and helps us. But we're doing it together with the individual. So this is where we will say in your interviews or your applications about collaborative working. That's exactly what it means. So we're not just doing something, taking information from the patient so that we tick box some forms that we need to. We are trying together with the patient to understand what they've been through. And so doing a timeline of events is really helpful, because the mind loves like stories and loves a nice coherent narrative. So the more you sort of go over a timeline in sort of the way it happens, it helps the brains to try to create this coherent narrative. Now, you won't get it like that from the patient, because our patients come to us because they're overwhelmed and they're struggling with their mental health or whatever. So you'll get it in bits. You'll get like bits from now or bits from childhood. You get it, and it will be like a puzzle all tangled up. Okay, so it will take time to sort of put it all into a nice coherent narrative, and we don't have to rush as a psychologist usually. If you're doing a specific assessment for an intervention, so for example, say someone's being referred to do anxiety management group, then the assessment process is quite straightforward. What we're doing there is really just assessing risk quite quickly, exactly. Definitely getting just some specific details about the anxiety. But what I'm talking about here is the assessment is sort of the bigger psychological assessment, and to try and understand complex
groups. If someone's been referred for a group intervention, you can very much follow like a textbook assessment. But when you know that this person has to come for one-to-one work, you have to take extra care and take exactly. Like,
so this is your therapy caseload, like your one-to-one caseload sort of type of assessment here, and you'll be looking at. I'm just going to draw something. I don't know if this is helpful, but like thinking in your mind of doing like a timeline. So if you did along here, sort of say this is stress, so like high stress, low stress, and then the person sort of, say someone was 30, and then like this is like their age. So what you want him to be doing is, you might physically draw this out with the individual and say this is the process we're doing, or you might just be sort of thinking in your head as they're talking about the different things they've gone through in their life. But what we want to get some sort of idea is the life, first of all, so any life events, what we call life events, are sort of significant things that have happened in your life that have added significant stress to an individual, or maybe trauma, but it can be things like divorce, or sort of bullying, or sort of traumatic circumstances, or grief or loss, any sort of significant life events or periods of change. We want to get a picture of those that have gone on, and sort of what sort of ages, because if we're finding out actually that someone's gone through a lot of change and significant life events, all sort of in the early years, and that gives us some sort of idea about maybe some we might start to understand why the person might sort of be dissociating a lot. It might be sort of a way that they've dealt with early trauma and things like that. But you don't need to worry too much about the theory and all that side of things at the moment. But just to gather some history, it's a nice way of gathering the history on someone and doing it with the person. And actually, when I've done it, people really like to do it this way when they start to see their life sort of. So what you do, so someone might just say they're 30, they might just say, oh, well, last year my granddad died or whatever, and so they don't do it. Very rarely does someone say, oh, okay, right, this is when I was born, and you just go along in a nice timeline. You can do it that way, but sometimes it just feels more like it's your agenda, and then the person gets a bit. Loses a bit of interest. Loses a bit of interest. So maybe they say, like, okay, people might start with the most recent. So they might say, like, okay, so my granddad died last year, maybe, and you'll say, well, on the scale of like stress, sort of say this is the highest you've ever been, that's the lowest. Where would you sort of say that fits? They might say, well, it's about there.
Say you could make the scale from like 0 to 7, for example. You could make that scale however.
It can be whatever. They can even say, well, that's 100 and that's 0. It really doesn't matter as long as you get some sort of idea of like the highest they've been, the lowest, and sort of relate it. So say granddad died, and then you don't need to go too much into it, or you can, it's up to you, but we've got a lot of time and we do want to get a picture. Then they might sort of pop to like, then the mind then might jump to other times when they've lost people. So, it might be that they lost, like, that then talks, and maybe you find out that they actually lost their sister I don't know, in a car accident when they were younger, maybe, so these life events start coming up, and they say, okay, so how old were you then? About 6. Okay, and where on the scale, and it is their perception that's important here, because your mind will jump and think, come on, blimey, I bet that was 100 on the scale, losing my sister, but actually it might be at 6. They don't remember much about it, or then so they actually might.
I guess in
might
this
rate that
situation, the client has a lot of control on the assessment, which is quite empowering for the client.
Yeah, and then it gives you a bit of a framework then to sort of say, all right, okay. So tell me a bit more about life at home when you were 6, and my mum split up and we moved around a lot, or we had, I don't know, these sort of stories people tell. It just gives you a framework. So then maybe say, I don't know, say started drugs or something. I don't know. So what you find, it's really hard off the top of your head to come up with these. You should maybe have case studies, but what you end up getting is like a bit of a picture that goes like this. Then really is really helpful. Then the people to see sort of their highs and lows, what sort of age in life was, and then it gives you sort of a bit of a framework to go on. Okay,
that can be useful as well if they don't want to talk about it. So if you could ask them about what age they were and how much stress it caused them, because then if it was like younger ages, you could think, well, it could affect the development or the relationship.
Absolutely,
and that can help you to understand how they're like that now.
Absolutely, and they might not remember everything right now. It gives you like a working document that you can come back to in next sessions and say, or if they start talking in future sessions down the line, you say, oh, we didn't add that on our sort of chart. Do you want to add that to your sort of picture and things? But also, what we're trying to get as well is a picture of their what we call protective factors and their resources. Because it's not all. What we're trying to understand is how they cope. It might be that actually they've developed a lot of resilience, a lot of skills from the events. How do we know a lot about how resilient you can build strength from having sort of adverse and challenging life events? It's all to do with like the context at the time and what happened. So they might actually have lots of support networks, or they might have a particular family member, maybe a nan or someone who actually they really, really connect with as a role model, and they're the protective factors. So you wanted to get an idea of what are protective factors as well. Maybe they have a particular skill. A lot in the prison, a lot of guys, particularly like boxers or whatever, like they don't have any education, but they have a skill. It's their like card. That gives them power in their life and be able to assert themselves. So we want to find out particular skills, particular people, and things like that, so that any protective factors as well. So starting to get a picture. So that's one thing that you can, because I remember as well, it is hard when you're starting out to know how you do this. So it's really helpful to just have a few things to do that that like, okay, I'm doing this. It's a sort of framework. So that could take you like 3-4 sessions, to do it properly and really well. You don't have to rush and really understand in person. So think of the assessment as a phase, like I said. It's not, you don't have to be in a rush to complete a document.
Is there like a name for this, or is this something that you've just thought of?
Well, you can read about it's a general stress vulnerability model. You can read up about stress vulnerability model, or the DIVE, I think it's called now, stress vulnerability model. This is essentially sort of it really, and what that predicts is that people have like a natural sort of built level of like vulnerability, like based on genetics, or some people are naturally just more resilient or whatever, and then depending on the stress of life, like it can sort of tip the balance and be into sort of poor mental health. But it's just a way of gathering history, like life events, or
usually I don't really like quite structured stuff, and I so this, for some reason, like it really works well for me. Just listening to it feels very therapeutic. If I were to put myself in the client's shoes, like I'd feel most comfortable disclosing stuff using this model.
Yeah, and the way this is, it's just a framework, because when you're starting out, once you like train, you're not used to it, like it comes a bit more second nature. But when you're learning the skill, you need some sort of framework. And this, and don't be frightened of it. You do it collaboratively with the patient and say, this is your life map, or whatever you want to call it, life map. I don't know, they use the language they want to use, but it gives you some sort of framework to start asking questions, so it doesn't feel like a dry interview. Another good one is something called a genogram. I've got you guys doing a genogram before. And a genogram is just a really, really good way of finding out more about the person's relationships and interactions, and you can understand about people's attachment styles, and so who are in their sort of life, really, because that tells you a lot about the person. And it's a really nice, and it's also just a nice sort of, once you've finished it, it's quite a nice picture to have. And
he made it out of card and made it glue it all together. And I've also used it. The most recent one I did was Swingers from a Gypsy culture. So their family was so confusing because they all named one of their sons is named after the dad. So you've got 4 generations of the same name. So I was like, right, we're gonna just start at you and then explain it to me, and then if they've got arguments in relationships, you then start to be able to highlight which one they're on about. So you can follow them more, so you're not always having to ask them who they're talking about. It's another really nice framework to just open up other questions as you're talking, and it's sort of organically, like a conversation starts organically then. So a genogram is you're probably best to sort of Google it after this, genogram, but just it's essentially sort of like a graph, a map if you like. You use I think it's squares to represent males and circles for females, and then there's all sorts of different shapes and things. You can get really, really quite technical with it, but you start off with the person. So I think they're normally, say if the person is in their early 20s, you want them down on the lower scale, because with each sort of row or column, each sort of row represents a new generation. So down the bottom you've got the younger kids. So say if someone is the mid to early 30s, maybe. So do you? Oh, brilliant. So you don't have any kids, so you'll be on the bottom. Do you have any? Do your siblings have kids? So you're an auntie. So you will still be on here. So we'll start you about here. So Rachel is female. So we'll do a circle. Okay, and we'll just put I've got 6 siblings.
So it's going to take a while. Rachel's got 6 siblings. Okay, so what we do here is we do mom and dad. So we do dad and mom. So dad's name David, and mom's name Sue. And then how you draw this is David and Sue had 6 children. Where are you in the line?
Number 6 and 7 obviously. Okay,
so there's 7 in total. So go 1, 2, 3, 4, 5, 6, 7. Okay. So have you got
4 older sisters?
So 4 older sisters. 1, 2, 3, 4. Brother,
and me, and
then a brother. And then I won't go into all the detail, but you can see how you've got the time. You can say, okay, so let's just get names and ages. And as you're talking, you can sort of say, you can open up conversations. Well, what's your relationship like with such and such or such and such, or who would you say you're closest with? And then you actually then draw a circle around who you're living with. Let's just say, for argument's sake, you're living with your mum and dad, and it's just you. You draw a circle like that. Okay. So that would represent who is in your family home. And then let's
just a lot of colours for this.
Yeah, you do. It can go on, and then say just for which siblings have kids.
This one has a girl and a boy.
So you draw it like that. So is the boy oldest?
Yeah.
So you do the boy first, and then the girl, and then you write the names and ages, and then any others. No. Okay. So all of a sudden you're creating a picture, and you're doing this with the patient, so that and it, like I said, it really helps if they've got large families, but also if it's sort of not conventional, maybe if maybe the person sort of lived with nan or lived with auntie or whatever, you'd find out this information, and then there are all sorts of ways of doing divorce and new ones, so it gets a bit technical. They have to I can't remember off the top of my head, but you'll have just Google it, it's fine, but this just helps. So then you'd say, you do. Does your mum have siblings? You've got to say a lot. So then she forms this line. So you've got,
she's the oldest,
thankfully.
And then she's got 3 brothers, and she's
1, 2, 3. So and then 2 sisters, like that. And then with dad,
it's got 2 brothers.
2 brothers. Okay. So you will very much, you can gather that you'll do this with the patient with a rough draft. First of all, there'll be a lot of scribbling down. I think even, how long did it take you to do a genogram with your?
Quite a few sessions, because he was one of those ones who was a bit more not unconventional. So he was passed around between family members as he's grown up, and he didn't really speak to any of them. So it was really difficult when he mentioned a brother. I was like, well, which one is this? Because he's mentioned and not spoke to them, so it's really handy to just kind of
take pride in it. Like he then,
and he really liked that. He was very crafty, so he cut up all the squares individually, glued it onto a bigger piece of paper, and then in really neat writing, and then he brought it to show us.
Perfect. So the first draft will be, there'll be lots of scribbles out and messy, and then just take your time. You'll be protected as an assistant psych, and even as a trainee. It's only really once you get qualified that you're under a bit more time pressure. But you'll certainly be protected as an assistant to take the time to develop these skills and really sort of do a nice job. So then it goes to your aunties. So then it will create like your grandparents.
And then there's stepmom.
So your grandparents. So who are your grandparents on your dad's side?
So it's my nan and granddad, but they both died. I think it's
so you put a cross if they're deceased. And then nan and granddad here. So see how it goes, and you can go up and up and up all different generations, or you can go as wide as you want, but it gives you a picture, and then it gives you a framework for them to have to open up all sorts of conversations. You can say, well, this brother, sort of how, what was your relationship like with this, or who were you closest to growing up, or who did you fall out with, who do you see yourself more like in the family, or what, it just opens up. It's just a way of, like, a lovely way of just having really nice conversations that don't feel like you're interviewing or assessing someone, because you're not. Like, you really are.
Shows you're taking the time to get to know them and appreciate them.
Absolutely. And then we're really wanting to understand, a bit, like, we're listening to the stories they tell and the way that the patient is talking, So if this is to start sort of saying, well, I'm the black sheep of the family, it's just think about the way people start talking about some of the narratives that they've heard, and you think, hang on, who's said that, like, where's that come from? Some of the narratives might be that it's some of the messages mom or dad might have said about them and things, so it's just other things to hold in mind as well. But it gives you an idea of who's in their family and how they're relating. So that's another thing. So you've got, when you're doing your assessment, you've got your your life map with your life events, and your genogram. It's another good one.
I think this would be really good in, like, the clients that come from ethnic minority groups, because I get the sense that they sort of feel like their mental health and any sort of therapy that they're getting has to be very, very separate from their family, because there's sort of like a stigma around being in touch with mental health services. This sort of opens the ground a bit, like, like, let's think about, like, your family a bit, how they've influenced your, like, narratives and things like that. So
absolutely, because it's if you don't go there, you're missing a massive. You're trying to make hypothesis, or you're trying to figure out what's going on for this person so you can help them without really knowing, like, a massive bit of who they are. And I think the worst thing we can do as healthcare professionals, but in a position of power, is make judgments on someone, and people who think, well, you think you know me because you've asked a few questions in one assessment, and you really don't, and all along you should never really be thinking, well, I know this person. You always just having hypotheses in your, like, just formulations in your mind, and you're, as a psychologist, it's part of how we do it a bit differently, really, because every professional formulates and assesses, but it's the way we sort of hold concepts and ideas and notice things just loosely, and we think, okay, that could be relevant, but it could not be, but we're just sort of noticing a lot more, just formulating and hold it a lot more loosely. I was going to say something, but I forgot. It should come back to me. But another helpful thing for the assessment phase is always like psychometric questionnaires. Like there's tons and tons of these, depending on what service you have. Like your supervisor will tell you the main ones, but that always is helpful when you're doing any intervention really, and it just helps our service look a bit more professional as well and clinical. But if you can do like a ratings, they're usually rating scales. These aren't big deals. Like I remember as an assistant just really like in my own head just blowing it up, like thinking this is like I've got to get this right, it's really not. Like they're just rating scales. They're just like they're just ratings. The popular ones are GAD-7, which is anxiety one, and PHQ-9, which is one for depression sort of, and they're your friend, they're your sort of, you use it as a way, another nice way of gathering more information. You don't have to worry that you're doing it wrong. It's not like a test. It's a bit different to if you were doing a neuropsych test, which is what we're covering today, but that's a very different process. That is very formal and has a very sort of structured way you have to administer that. But with a questionnaire, like a rating scale, like the GAD-7, PHQ-9, there's all sorts depending on what you want to measure. What did we do for the trauma? I think it was impacting event scales and the dissociative experience scale, the DES.
I liked that one.
The DES.
Yeah, because it's like you can pick which ones. So you rate it, and then you pick the ones that they've scored the most on. And then you can sort of categorise them.
Yeah. So it does give you a bit of a picture, and it just adds to your assessment as well. But it's also really helpful because you've got like a quantitative sort of baseline before you start with intervention.
You can measure their progress after.
Absolutely.
And when I've done the
managers love it.
When I've done the psychometrics as well, you can use it to ask them more questions. So I think in the PHQ-9 it says, do you have any thoughts of hurting yourself or being better off dead? So then I always then address that. Especially with the community team that we work with at the moment. I've been doing these over the phone with people I don't know. So every time I stop and say, can I just ask you, is your care crew aware of that? And I've actually had someone the other day saying they're not sure. So I'm glad that I did mention that, and then I've brought it up to make sure they knew. If it's someone you meet for the first time, they tell you that, you can then start to go and ask them, is it just thoughts? Are you making plans? And then you can take that seriously as well. But gather more information by using those as baseline.
Yeah, absolutely.
It's good because these psychometrics, they might sound a bit too structured, but at the same time it's your risk assessment, it's your psycho assessment all in one sort of place, and it's also something that managers would like to see, that you've got something there.
Well, it like they've been they're standardised for a reason, so they've been tested on, so that it's just, that if you're doing the PHQ-9, you're asking the right sort of questions to get a feel for how depressed someone might be at the moment, and if you're doing the GAD-7, the general anxiety disorder, you know that you're asking the right questions to know about anxiety, so why recreate the wheel and try to, is that safe? Why use what cleverer people have already put together, that these are just, it does help you increase your confidence as well, you're asking the right questions, but then, it also gives you a framework for then expanding on certain questions. If someone sort of says something and you think, oh, that was interesting, just tell me a little bit more about that, and you can spend the whole session just talking about the using that a questionnaire, it's like a rating scale, just using that as a format for developing your therapeutic relationship and trying to understand more, so they're sort of three helpful just tangible things, it's always really, when you're learning, I find when you're learning, it's always really helpful to just have something you can physically hold and be okay, if I do this, I'm on the right track somewhere, so if you're trying to, if you're going to do a life map or genogram or a questionnaire, you're doing all right to gather information.
And in the assessments, we'll take a formulation sheet, which it'll be focusing on the next webinar. But then if they're telling you information, it saves you going back over it with them again. So then I'll make notes in the right boxes, and then I'll start to do it, and then obviously you include them whenever you do that.
Yeah, absolutely.
And you'll pick one that suits your therapeutic style the most. So, for some people it might be doing that 5 Ps thing. For some people it might be this stress thing that you were talking about. It's all down to what fits well in your style.
Yeah.
Then as well.
Yeah. But we'll probably go on to the 5 Ps that you mentioned next week. I talked because that is the main one when you go training. That's sort of the first one. It's a nice framework as well, and it helps to sort of put it together. And that's good training. The first thing will be taught. So if you can have a good understanding about it already, that's really, really helpful. Yeah. I'm just trying to think about some personal examples, about like as a psychologist in the team, you might even start, as you get more information, you might even start developing formulations that go against, as you gather in your evidence, that go against the sort of dominant narrative in the team. And that's part of being a psychologist, really, because there'll be a lot of talk about symptoms and sort of very medical, but it might be that, particularly when we're talking with people with personality disorders, you'll notice very sort of problematic language sometimes, really, where you really don't get people talking about personality disorder, and you really don't get a flavour for the individual. Or someone to say, well, this person's, like just impulsive, can't control their, and very sort of fundamental, like, blanket statements, can't control their emotions, they're really angry, like it's just part of their personality disorder, things. And without, and as you're hearing these, you're thinking, well, I'm getting no impression here, understanding of the context of why the person's losing their temper. I have no idea about the context, no idea about why this person has a personality disorder, why they've gone, what they went through in their earlier life to develop difficulties in their personality. I don't know anything about this. I don't know anything about the individual you're talking here. And they just talk about, so the team will talk like this. So it is our role as psychologists to start to understand the individual and the context, why is this person getting, it's not that you can't control emotions. We need to understand what is triggering it. And what's going on for the individual and why they're sort of overloaded so much, and really start to understand. So it's really us as a psychology, really have to sort of take the time to ask the questions nobody's asking, really try to understand. And sometimes it will be about having to challenge, or challenge sounds quite aggressive, but it's like it's like, that's why question. And it's why I like the way we work as psychologists when we're talking about formulate, because we're just sort of questioning or just throwing in other ideas into the pot, So I remember a guy that I worked with, a patient, when I worked in forensic learning disabilities, sort of medium secure setting. So this is like patients are there for a long time. There's a 16-bedded unit, and we know a lot about the individual, and it's almost been, the individual has almost been over-assessed, and the sort of dominant sort of phrases are coming out. And this individual, the psychiatrist and people were sort of saying he is part of his personality disorder that he inappropriately was touching a female staff, the same one, and they said sort of he was targeting, and he was sort of manipulating staff, and there's all sorts of, like, the way we start to use language as professionals in a team that it just kind of makes you feel a bit like you're listening to your instincts. You think, there's something wrong here with the way we're talking as professionals, and we need to change it, because the language is used, it's personality disorder, he's manipulative, he's trying to sort of use a way of pushing boundaries and stuff like that. And I think when I assessed a bit more, I actually sort of found out the dissociative experience scale, I actually found out he was actually dissociating a lot, and he had a lot of moments throughout his day, and like where he just was losing chunks of time, So where the team sort of thought that he was purposefully, sort of intentionally trying to target a member of staff, actually it was another idea I had to throw into the pot, and it wasn't liked, but I had evidence to sort of back it up and say, well, actually there's some dissociation going on here, and I'm not 100% sure that he's aware of what he's doing, and he really, that really then sort of was common sort of opinion, but as psychologists, as we're gathering information, and we have sort of evidence about how the brain works, particularly with, if we know we've got a patient here who has had chronic abuse as a child, you know, and with a learning disability on top of that as well, we can say it is quite likely that this person develops sort of dissociation, the mind dissociation, to cope with it. You know, so when the stress is getting too much in life now, the mind's sort of putting out. But then when you have experience of that in the session right in front of you, which I did on one occasion when you stress fed something, and you can physically see a dissociated state happening, you know, you've got more evidence to back up as well. But as the point being, it's about sort of asking as a psychologist the different questions, but you'll be guided by your instinct, you know, when and listen to that. It's almost sort of better when you first come in to a team, because you are hit straight with the sort of the narratives that the team say, and you don't want to habituate to that, and unfortunately people do, you know, and then start sort of saying the same thing that everybody else is saying. But you have to listen to your instincts. You say, hang on, it's like we're losing the person here, you know.
I think that can happen a lot day to day, but on a smaller basis. So when people are referred to like our psychology team, they'll put like for anxiety. So when you do assess them, don't just focus on anxiety, because there could be a trauma reason behind it, and actually you need to do stabilisation with them rather than focus on their anxiety. And there could be something else, obviously anxiety, depression, the comorbidity. So you might need dual work on that. So don't just focus on what they're referred for.
Definitely
kind of get the big picture,
but
then look at what to.
But that's where that's where doing your lovely life map comes into it, because someone's been referred to prisoners as say, well, they can't control the temper, or just really a really aggressive person, or really unstable emotions. But then actually you find out that this person has had quite significant head injuries, like a few times throughout their life, and you think, hang on, there might be some traumatic brain injury here that's been diagnosed, you know, and you get that from doing your life map. If you find out someone, particularly if you add in sort of factors like sort of heavy drugs or alcohol, and then you find out when you're doing significant life events that happen, you think, oh, I spent 2 weeks in prison, 2 weeks in hospital when I was like 15. It's like, oh, what happened there? It's like, oh, I fell off a second story roof onto my head or something. I don't know. You think, okay, all right, okay, this is helpful information. Like, did you ever, like, what, you know? And so you find that information, you're just holding that in mind, formulating, like, okay, well, this could be something here, and then that leads to your intervention or treatment plan, because then you would advise that we need further cognitive assessments to understand the functioning, you know. So it's all these sort of things as psychology team we're really asking more of, and we have the privilege to have a bit more time for assessment. But I think the bullet point I really wanted to make was that it's not like you're just going and doing an assessment and you're following a script. Just think of it as a phase, and take as long as you need, because you'll have that privilege as assistants to take as long as you need to be in that phase to fit. Don't be in a rush to make judgments. Well, we never make judgments anyway, or assume. We're always just sort of formulating, and then we'll have some sort of hypothesis that once we've got enough evidence we're working with, but it's just can't, when there's new information, we take that on board, assimilate that, and sort of move on. It's always been
a lot of the people that are attending are probably like support workers, and they're like psychology graduates, so they actually have all the time in the world. Like, they don't have like time limits to do work with the client, because they're not really meant to be, not that they're not meant to be doing work with them, but the job role is for the psychologist and the psychiatrist or the nurse, whereas a healthcare assistant is just supposed to like assist that client's care. So they have more opportunity. I think they have a lot.
But your healthcare assistants, support workers are valuable like resources to you as you're doing your assessment, because they will more often than not, well, they'll be the people who know the person the best. So you're not just gathering information. If you're doing a really comprehensive assessment, I mean, you don't always have the time, but if you're doing a really comprehensive assessment, you're gathering information from the sources. So you get from the individual, and then people who know the individual, if the context is right, you'll be speaking to family members and getting their information as well. You know, as much information as possible from different sources. You know, because not always, you know. Well, usually when people come to us, they're a bit more stable. So you don't have to go down the route really of doing a mental health assessment, where we have to sort of that's where you're really thinking about sort of how people are speaking, and sort of like their eye contact and that, you know, that sort of more. If someone's really unwell, you know, if someone's acutely psychotic or they're in a really sort of manic phase, then the psychiatrist or the team, you know, they wouldn't really be then referred to the psychologist. Usually, sort of when someone's more stable on their medication, that's usually when someone comes to us. So we don't really have to be too bogged down with trying to understand what a mental health assessment is, but it might be helpful just sort of having a bit of research yourself, because that's what psychiatrists will be doing when they're trying to assess their patients. They're really looking for the rate and the tone and the fluency of the speech and the sort of the way they're putting words together and just how someone looks and presents. So there's a lot of information. Nurses will sort of pick up on that as well. So it'd be good to have an understanding of that. But yeah,
I think we should be open for.
Yeah, because we didn't get a chance last time. Yeah. There's only 10 minutes or so left. So
if you guys have any questions, just type it in, or you can unmute yourself and
just get some water.
If you want to type in the chat any sort of questions.
Yeah, type in, or just unmute if you feel comfortable just speaking.
I thought you were listening.
Yeah.
Actually, I was just thinking about the timeline, so we have as much time as possible, and I think like within the prison that we work in, because it's been remanded, it's such a fast-paced thing that people do tend to lose like some aspects of these skills. It's always good to have a refresher and just kind of like go back to the very beginning and do it all again.
Yeah. And that's why we're talking here. This is like when we're talking about your therapy caseload here, or someone where there is the time, like when you're doing group interventions, you don't really have the time. But then it does depend on the context you work in. So if you're doing group interventions in a ward where people are sort of there for a while, then you've got the time to do that. Yeah, but we work in
Someone's asked, any recommending reading around the 5 Ps?
Yeah, I mean, I'm going to come on to the 5 Ps next month, but you just I've got a book.
The worksheet that I use as my basis for the 5 Ps is actually off Psychology Tools. So I think you have to sign up and you get like 5 free downloads. We have to normally pay for it. My worksheet's up there.
And this is a good book as well, but it's just like the main sort of models in formulation, which is CBT, psychodynamic, and systemic. So this covers that. But formulation in psychology and psychotherapy by Lucy Johnson, Rudy Dallas. I think I don't know if that's a good one.
Oh, it's well backed, but I'll write it on my pages.
But I'm going to next month. That's what I'm going to cover is the formulation bit. So if you can hold on to next month, I can. I'll be going over it a lot more then. Because I've tried to split it up into assessment and formulation intervention, but actually in reality, the lines are blurred, and you are assessing and formulating almost like chicken and egg sort of scenario, like what comes first. It's sort of a bit of a it does.
And one thing that I noticed throughout all our stages is that I always check their motivation for engagement, because if they don't want to engage, then they're not going to achieve the most progress.
Yeah, absolutely. And that's how your sort of assessment report usually, that's how the assessment report would be structured. If you are your therapy case, you do have to sort of write up an assessment summary, and it's sort of just not a massive thing. I've seen sort of, I've been guilty of this myself, of writing pages and pages and pages. And you think, who am I writing for here? Because psychiatrists and GPs won't read it. Like, the patient won't read it. Like, you're doing it because it makes me feel like I'm clever. And if you're doing it for that reason, then stop and think, because it's really unhelpful.
Yeah.
And also the skill comes in consolidating and being concise. That's where the skill lies, and being able to know what to edit out. So it might be that when you're writing your assessment report, it's about 5 pages, but you need to get it down to a page or so, really. And it's just like the main point. So it's sort of, reason for referral. And it'll be motivation, like a summary of their interaction, engagement, and motivation, and then a bit of a summary of like their history, and then sort of your formulation. And then, once we finish the formulation next month, I'll talk you through a report. But usually, you don't even now, you don't really need an assessment summary. What tends to come is a psychology summary after intervention, but it depends on the service and how controversial maybe the intervention might be. Not controversial, but if you're saying that you think this person needs a lot of therapy, maybe for 10 weeks or so, then you're going to want to have an assessment summary just to justify that, really.
We've got two questions. One says, how many sessions do you, I know we usually say that there's just like an assessment period, but I think this person's saying, how many sessions do you usually spend on the assessment?
Yeah, I mean, and it depends how you frame it as well, because you could easily say that doing a life map is an intervention, so that could go into intervention phase. I think, roughly speaking, like 2 or 3 sessions is enough to build up a rapport and to get a gist, to get an idea of where you might be going. It's never set in stone. You never should have to worry that you haven't got all the information, because you never will. And if you ever think that you've got all the information, then that's really it can be really unhelpful.
It will change based on the patient as well. So you can have one patient who's had loads of like several trauma experiences or really traumatic lifestyle. Or you could have one person who's had one big event.
Yeah.
So their life map is going to be a lot quicker to complete.
And like the patient will want to feel like there's some intervention here, so they will want to spend weeks and weeks in an assessment phase. But you might get all the information you need in one go, or it might be that you need 2 or 3. Usually about around 2 or 3 would be enough for you to have had enough information to come to some idea about where you're going to go, and then what's going to go on the care plan, the psychological care plan, which I'll talk about next time as well. Hope that's helpful.
Someone else asked, in terms of understanding the role of clinical psychologist, what are the timelines like when unprotected? The distinction has been drawn with AP and CP timelines.
That again, sorry.
In terms of understanding the role of clinical psychologist, what are the timelines like when unprotected? The distinction has been drawn with assistant psychologist and clinical psychologist.
Would you mind coming on the chat? Is that Jodie? Because I'm not quite sure. Is it Jodie?
Yeah.
If you don't mind, or just typing in a bit more, because I'm not sure I understand what you mean. By
yeah, no, I don't mind. It was basically, you commented that that as APs you would have time, and your time would be sort of protected, and you should take your time over the assessment. But you kind of drew the distinction between being qualified and that maybe there was more pressure. Just in understanding the role in terms of applying, I just wondered whether what sort of the difference was, if you like how much faster expected to kind of cut with things as a qualified.
So as a qualified, not really the newly qualified. So once you finish training, you go to band 7, which is newly qualified, and you've got a good year though there, really sort of get to good things. But then once you go up to band 8, you really are expecting to have formulated by the end of the first session. In really complex cases, maybe a couple of sessions, but you really have. But it takes years to develop, to know what to ask and to develop this. That's why it's designed that way. Why, as an assistant and a trainee, you are given the time, you're given smaller caseload to really understand the skills. But as a qualified, by the time you get to band 8, really it's expected by the end of the first.
Happened there, but it was saying something like, how do you adapt a psychology assessment to a crisis setting? So.
Well, the assessment for a crisis is a very different situation entirely. You're talking more like mental health first aid here, where you're trying to assess immediate risk. I think as a psychologist, I've never worked in a crisis service, so it's hard to answer that. I think my instinct is that you'd be looking for immediate risk, and trying to find out specifically people's plans to harm themselves or to end their life. So you don't necessarily be put off if people are scared of people saying that they're thinking of killing themselves. That's actually quite a common symptom of depression. But what you want to be asking, you want to find out more information, is actually if those thoughts have turned to plans and intentions, and they're visualising and actually putting things in place, and that's when the risk goes up. And if they have means to do it, and most certainly if someone has a history, then we know in their history that they actually have tried to kill themselves before, so that again increases risk. And
But we're talking about assessment here in a crisis situation is risk assessment. So that's not necessarily always just down to a psychologist, whereas it's part of. But when we're talking about the full psychological assessment here, it's a very different process, where you're taking a lot longer to understand the person and their history. But yeah,
I'd probably be wondering as well what set off their crisis mode. So is that something that's going to be happening more frequently, because that's it just gives you an understanding of that, or is it something that you deem more that's less frequent, or just helps you understand it a bit more, I suppose?
Yeah, so you just want to be accessing, thinking what are their resources as well? Is there anyone that they can ask for help, or is there anyone they can reach out to? Try to encourage. There's a bit more active when you're assessing in a crisis situation. You wouldn't necessarily be asking someone to really reflect over what they're thinking so much. You really want to get people to they're not really sort of reflecting on the trauma in their head. You really want to get people to think, to reduce the arousal, so it's just trying to sort of bring, that's why we talk about stabilisation skills, really trying to get people to connect to calmness and safety in their body, teaching these sort of coping skills, and absolutely sort of normalising it to the person and saying, that actually it's a really good sign if someone's sort of talking about how they're feeling, that's really, really helpful, and really sort of try to encourage people to access other sources of support as well, so it's just not you as their lifeline as well, there are other people, so signpost them to services or other things.
And you could even encourage them by giving them kind of validating, saying what you've noticed in a crisis mode that you need the support, and you've gone and accessed us.
Yeah.
So kind of giving them that.
Diffuses the situation a little bit.
But encourage them and giving them praising them, I suppose.
Yeah.
I think if someone is seeking help in a crisis situation, if someone is coming to you saying this is happening, then that is all really, really positive. So as a professional, you're there to listen, and you're there to just reinforce the hope. Absolute sense of hope. Absolute sense of hope, and not to sort of reflect back any sense of panic, even if you feel the panic and you think, oh God, not you portray, or you to reflect back absolute hope and absolute this is normal, and that you're fine, we're here, we're going to look after you, okay, that's that sort of stuff. So
I think in a crisis situation, and assessment and sort of the stabilisation skills that you'd teach them in the intervention period would go hand in hand. Be prepared to teach them a few things that would be appropriate at that time.
Grounding techniques, breathing techniques.
Just be very sensitive and be aware of what you might be faced with in that situation.
Absolutely, because that's why the grounding techniques are helpful, always to bring people back to the moment. If something's triggered off a trauma memory, remember that's sort of sensory memory, so it's sort of live in their limbic system. They can't control it. What you need to do is bring them back to the present, that's what grounding techniques do, almost reminds the brain of the boring, normal reality that they are, so there's no threat. Do you know what I mean? That's what you're doing. So you're physically saying, touch, tell me what you can touch. This boring chair, there's nothing threatening about it, it feels smooth. You're bringing the brain back to reality, it's grounding you. So tell me some things you can taste, what's some things you can hear. And it's reminding the brain, this is where I am, I'm safe now, almost sort of dull and it's sort of boring, and
there's so many grounding techniques that they will be able to find one that works for them.
That's why the stabilisation skills are really good as well. The one with a safe place and calmness. So
Contained imagery, I think it's really helpful.
But that will be more in your intervention phase. If you're faced with assessing someone as a crisis, what you're talking there is trying to assess the immediate risk. So does someone plan to kill themselves? Have they been visualising it? Have they written letters, or do they have means to do it? Have they done it before, and failed, and they're intent on doing it? These sort of things should sort of ring some alarm bells, but not alarm bells for you to panic, but you to think, right, okay, what do I need to do to make this person safe? And in that case, you're going to have to use other people and get a bit more. Think of it a bit like with physical first aid, because we're talking here, it's like mental health first aid. So physical first aid, the equivalent would be a cardiac arrest, wouldn't it? So what you're trying to do there is stabilise the person, would get help as well. You're the person sort of stabilising whilst they're getting more help. Think of it a bit like that in an absolute crisis situation. So the key point to remember, as an assistant psych in that service, you will not be on your own. All right. So if you can just portray sort of a level of calmness and safety for the individual, then you're doing all you need. Okay, you do that by whatever means possible, you know, use your own techniques or whatever, as long as you portray a strong message that you're fine, we've got you, you're okay, and you do, you know, then you're doing a great job.
Yeah.
All right.
I think that was the only question that I can remember, but I'll try to figure out what to do for next time.
So apologies about that,
yeah.
but please message Saba, or I'm on Instagram at Grave Banana, so follow me or message me if you have any more questions. I'm here to help, that's fine, it's no problem. And then we'll do this monthly, and if people are still, we'll do it for as long as it needs. If people are interested, we'll keep doing it once a month. So, but the next one is about formulation, so we look forward to having people on that.
Yeah, all right. Cool.